This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
As a clinical intensivist, and Nijmegen is a town in the eastern part of Holland, we claim to be the oldest city in the Netherlands. And as you see on the bottom picture, our emergency team, because distances were quite large, and that way we could reach patients in remote areas of the clinic a lot easier. I hope the reason that the organizers asked me was because we have a pretty mature med system in our hospital. We started over 10 years ago with our med system. We adopted several different ways of calling criteria. I think this is version number 6, and we also integrated our sepsis criteria with the MET criteria. That's the reason that we have some orange numbers which correspond exactly with the surviving sepsis cutoff points. Our med dose is also pretty high, you could say. It's stable these last years, so the first introductory slides of Bill could really correspond to our hospital, and we are very well appreciated throughout the hospital. It all turns out to safety, and safety is as we all know, a big issue. This came back in previous talks already, and also in the Netherlands this became aware to the government about 10 years ago that we have many avoidable deaths in our hospital, and you could say that the start of the medical emergency team was the same time that the government started to implement several ways to improve our health system. And it's true that in the last analysis, quite recently, the amount of unexpected deaths has really dropped down. And cause number one of problems is not lack of clinical skills, because that's in general pretty much okay, but it's communication. And I think that's also what we learn these days, that the improvement of communication, of team training, is a sort of key issue in improving our health system. What we did, and I can only talk about personal experience, what we did in our hospital, is always to have a nice slogan. That's very modern. I mean, all major companies have slogans, and very often it's a sort of open door, but we said that we want to have a significant impact on healthcare, but we try to live up to that slogan. And what we did, and I think that's the sort of key system about how we improved our system is to introduce 11 safety themes, and recognizing the deteriorating patient is one of those safety themes. The second thing, and probably that's the key, is education. The third thing is crew resource management. I will allude on this very shortly, very briefly. And the fourth theme, which came up quite recently, is the hospital at night, or as we call it, the evening, night and weekend problems, because that's also recognized as a very significant problem, because more complications occur in those odd hours. These are the icons we use for the safety themes, and yeah, you can recognize by the little images what they refer to. It's like improving the problems of contrast nephropathy, is improving the cardiac care. But in red, it's the theme which I always find the most important one, is the clinical deteriorating patient, because everything, well, you could say, goes back to that theme. And what we use in our education, at least what I use in my education, is examples, because examples are always strong. It's the same as my previous speakers did. They always stick to your mind. And this Mrs. Johnson is a sort of, you could say, an average patient we meet every day in our hospital. She's admitted to internal medicine with abdominal pain. She has diarrhea, dehydration, anorexia. So you can see there's a lot of problems going on, and she happens to have a colon carcinoma. Her past medical history is, well, you could say also pretty average. She had a lot of comorbidities, and she's on several drugs. So there are a lot of safety themes involved. And you can imagine when we have a smaller audience, I could ask it to you, but I will answer the question myself. You could certainly imagine that in such a lady on the general ward, the safety theme of the vulnerable elderly is very significant. And there are many problems around those patients, and you can imagine if you concentrate on those issues to improve your system, you can really improve the care of such a lady. The same thing is when such a lady gets a CT scan with contrast, well, she can really get into trouble, and so it's very important to prevent acute kidney injury. Medication, it's always a big issue. People come with a lot of drugs in a plastic bag, and I think it's a very important task for us to get rid of redundant medication, certainly in the elderly patient. High-risk medication, you can imagine if you admit such a lady, there's a lot of high-risk medication which can create problems instead of solving problems. And you can imagine that a lady of this age very often has an increased risk of coronary syndromes. And finally, she will have pain. And pain is, as you all know, it's a difficult problem. It's not on our standard checklist for recognizing the deteriorating patient. It's often sort of a worried sign thing. So as I said, education is key, and that's what we decided to concentrate most on when we were discussing how to improve the system. And well, we heard about the problem that there's a lot of attention to acute life support, to advanced life support, and it's true that it's probably better to concentrate a phase earlier on. Although I still think that the acute life support training is a very good example of very tight team training. So I still think that advanced life support is valuable, although it's only a minority of the patients, and we probably spend too much money on it. But it's a very good example of good team training, and that's the reason we still find it very valuable. And as we use the alert training as a example of how to increase awareness for the deteriorating patient, still a difficult word. And there are a couple of, you could say, golden themes, which is, first of all, the ABCD methodology, that we say, if you're lost, always go back to your ABCD system, and use good communication skills, and it can be SBAR or RSVP, whatever. And it's true that you really have to enforce this, because people easily go back to the old way of communicating, which we all have known creates problems. And then team training, that's also alluded to by previous speakers, that it's very important to have training with doctors and nurses together, because we happen to speak different languages, and I think by combining this, it really improved the way we worked. And then what I really like is the slides from Alex Psaridis from New Zealand. He has the A to F of bad trainees, and that's what I also use in my training, because it's very instructive. And he also taught how to improve that by the A to G of good trainees. And I think that's very important, how you really learn fellows who are basically clinical specialists, how you train them to improve your communication skills, because that's very often where it goes wrong. So Mrs. Johnson, she deteriorates, as often happens, in odd hours. At 10 o'clock p.m. she gets confused, she falls out of bed, and she gets drowsy. So that's all, well, very serious. And you can imagine that these safety themes are now involved, and it's now very important that the nurses know what to do. And as we all know, the afferent limb of the rapid response system is the weakest link, so it's very important that we train our nurses that they know what to do. And as you can imagine, in this lady, this becomes very critical, and also here time is the essence. And this is the famous slide from Gary Smith, which shows that the rapid response system is a chain. It's a complicated system. You could say it's pretty difficult to really implement in a good way. We can all say that we, like in Holland, 90% of hospitals have the rapid response system, but I'm pretty convinced that in the majority of hospitals it's not very mature, and it's still there on paper, but not completely sunken into the system. And it also took us almost a decade to really have a good system which is well accepted by the whole of the hospital. So then the third step of my 4 steps, that's crew resource management. That's something which we, you could say, we championed in our ICU. We had a resident who was also a flight, a pilot. He was a pilot, and so he introduced a system of crew resource management, which was at first, well, skeptically looked at because it's time consuming. It distracts your attention from the why you are at a patient. But now we are really aware that it's a very good system of preventing mistakes and of preventing problems that you don't see the big thing. So it's complex to introduce, but it's very important to realize it's a team concept, and it's a sort of that you all agree on a code of conduct, collaboration, and communication. And it's funny to see that we started this about 5 years ago, and now the rest of the hospital gradually follows us because they see that we get good results in our ICU, and we now serve as a sort of example for our hospital and even for hospitals outside of our own region. So the goal is to use all available resources. I will not go too deep on it because it's a separate talk in itself, but it's all about optimizing patient safety. And you have to use all the helpers available, and there are many helpers available in your hospital. You're never alone. And it starts before the problem occurs. It has 15 points. I put them just on the slide so you know you've seen those points. First I had 15 slides to introduce them, but then Michael will not be very happy. So let me just tell you that it's also complicated to really introduce because it is something. It's not only 3 points, it's 15 points. So my lady, she deteriorates, she gets to the hospital, and she needs a central line, and then that's also a separate theme which gets a lot of attention to prevent line sepsis, etc. And by introducing the central line, we use checklists, and I think most of you know about this, although I think in the rest of the world it's still a relatively new thing, that you really start introducing yourself, name the points you want to follow, and also do a debriefing afterwards. So it's easy to start, but it's also a challenge to maintain, and that's also by giving attention, giving regular team training, etc. Then finally, one slide about the early evening, night and weekend. It's a recognized problem, and we really did our best to improve that by training the staff to be more aware of the fact that in odd hours shit happens. So the solution is that that we have to be aware that residents need a better training before they are exposed to these ENW hours, because in the old days it was often the case that you get exposed on calls on your first shift, and now we are aware that you need at least 1 month of training, and that probably some people need more than 1 month of training. And then it's all by giving a standardized introduction program. Okay, so making the system safer, education is key, particularly through simulation training and refresher training, introduction of, in our hospital, safety themes. So it's also, you could almost say it's sort of silo, every theme can be a silo in itself. Crew resource management is a very important concept, and the hospital at night or evening, night, weekend. Well, final slide. Our lady, she gets pneumonia because it took a little bit too long, and after several weeks, she's sufficiently improved to discharge. And you can imagine that there's still safety themes improve even when you discharge this lady. So this is what I wanted to tell you to improve your system. Thank you very much.